everybody. Good afternoon. Welcome to today's Palliative Care Echo Clinic. So glad you could join us. We'll start off with introductions here in the room, and then we'll go out to all of you joining us. So hi, I'm Troy Jorgensen. I'm the program manager here for Project Echo Nevada.
Hi, I'm Sneha Sharma. I'm the admin assistant for Project Echo Nevada.
Hi, I'm Hub Team member Dr. Jonathan McCaleb.
Hi, I'm Suren Furuhi. I'm one of the geriatric fellows.
Hi everyone, Elena Proshkin. I'm one of the geriatric fellows.
All right, and Kim, if you want to go ahead for us.
Hello everyone, Kim Anderson, Hub member.
Thanks, Kim. And Jessica, our other Hub member.
Hi, it's Jessica. I'm clinical pharmacist at the VA.
Thanks, Jessica. And we'll go out to our other sites joining us today. So Kelly, please go ahead.
Hi, this is Kelly Presser. I'm the clinical nurse leader at the Reno VA.
Thanks, Kelly. Always good to have you. Kendall Lyons, I've unmuted you. If you could introduce yourself, please. Kendall, are you there? Do we have audio for you today?
Yes. Hi. Sorry, I had to unmute my computer.
No problem. Please go ahead.
Hi, everyone. I'm Kendall, and I'm with the American Cancer Society here in Southern Nevada, and I will apologize in advance. I have a 12:30 call, so I'll be jumping off early, but I will catch you on the next one.
Wonderful. Glad you could join us today, Kendall. Next, we'll go to Dr. David Bayun. Dr. Bayun, I've unmuted you. Could you introduce yourself, please?
Yeah, I'm David Bian. I'm a hospitalist. I'm in Ely this week.
Always good to have you, Dr. Bayun. Thank you. And next is Lori Stanfill. Lori, if you could, yeah, there you go. We're unmuted now. We could hear you for introductions. Lori, do we have audio for you today? All right, if you could just write it through the chat box, the rest of your information for us, that'd be helpful. And then Dr. Levy, are you there? Can you do introductions, please?
Hi, I'm Dr. Levy. I'm currently the medical director here at Project Echo Nevada and also a UNRMed geriatrician. Nice to see everybody.
Thanks, Dr. Levy. All right, so we'll open it up now to see, does anybody have any patient cases that they'd like to run by the team today? Any questions, cases, that sort of thing? Feel free to unmute yourself with the microphone icon in the lower left corner of the Zoom window. *6 if you're joined by telephone, or if we don't have audio for you, you can write it through the chat box. So any questions or anything we can help you with today?
I have a question, if that's okay.
Respectfully, go ahead.
Cool. So I see a lot of patients in the hospital that have had acute traumas, and sometimes they can have some significant pain. Often, what I've actually been hearing a lot of recently is, as we attempt to improve their pain control and attempt to kind of manage their cognition as we treat their pain, people are in a lot of ways, I have to often kind of reset expectations with regards to what, palliative care and kind of weighing the risks and benefits towards a lot of treatment options, and kind of dealing with these specific trauma patients who, either had an MVA or had a skiing accident, and are potentially having a lot of, psychosocial or psychological changes as far as their functionality, and pain potentially being part of it, but not really being all of it. When you have a broken bone and or sitting in a hospital, there's other things that can limit your functionality. How would you kind of best, I guess, advise the hospitalist or the person seeing the patient in the hospital as far as how to kind of manage that conversation when the patient themselves says, how come I'm not getting more palliative care?
Right. Thank you so much for that question, Dr. Levy. That is a really, really very timely and pertinent question. So with patients such as in the profile that you're you have outlined. So we're talking about a patient who may have sustained multi-trauma, and oftentimes I definitely agree with you that we need to frame pain management options through the palliative lens. And what I mean when I say that is that oftentimes as geriatricians, of course, part of our goals are to optimize function and increase the likelihood of a better functional outcome, but also one that it diminishes pain at all costs. And so one of the things I can think about in answer to your question is, and I like that you framed this in the idea of pulling this out of your primary palliative skill set, because you can get a palliative care consult, of course, but this ECHO is making an attempt to empower clinicians such as yourself to have these conversations firsthand and at the bedside. So how I would manage that is I would be clear about defining the patient's goals of care from their perspective in that moment in time. And so I would start, again, because I'm initiating this kind of a conversation through the palliative lens, I would advocate explicitly discussing with these patients the fact that while the pain medications have several side effect profiles, including cognitive changes and including other side effects such as constipation that we can definitely mitigate, that we realize we're using these in a risk-benefit profile that can be very challenging. But ultimately, I think we rely on the patient's perspective in terms of the importance of the pain management and their functional outcome, and matching our pain control efforts towards that end. And then we just have to be very explicit in our documentation that risks and benefits of such and such narcotic were weighed with the patient and their family, and the family feels strongly that the benefits of pain control in the setting of improved functional outcome outweighs the risks of the narcotics, including side effect profiles and cognitive concerns. And so I think by even making that short of a statement, you really set yourself in a position where you've now partnered with the patient from a goals of care perspective, and you've also opened up a space to optimally medically and pharmacologically manage the pain issues in a multi-trauma situation, which can be overwhelming, to say the least. So that's kind of where I would stand in terms of having the conversation. And the only other thing that I would add is that a patient in that situation would, of course, be somebody who you would be looking at for adjuvant pain therapies outside of opioids, and especially when they feel that the risks of the opioids outweigh their benefits, then maximizing adjuvants and making sure that you've identified those different types of pain. So that's, I'm sorry, it was a long answer, but that's my answer.
Thank you.
If I can add on to it too, I love this format because we all get to be a part of it. And so although you all are looking at it straight from the clinical side, I would really see if you could pull in a social worker and ask for a psychosocial, not so much of as an eval, but just maybe, are they looking to do some other things besides just the pain management? And I don't want to say just, but, is there any possible way for meditation or, even just some community outreaches and partners that may be looking to be more supportive with these patients? So you might try the social worker in the hospital. And if you don't have, with you using this example of a hospitalist, but also if they don't have a social worker, you can reach out to a hospice partner, they have to have a social worker, and most of them are more than willing to go ahead and talk to that patient because, again, it's the patient and the family that we really want to help. Additionally, if anyone has ever used the FactPal for conversations, it's a great tool. We could possibly look at doing a session on that. The FactPal is a great way to really start some conversations with the patients as well as the patient's family and have realistic expectations. And as you said, maybe resetting their functionality as well.
Thank you. Appreciate that.
Yeah. Great
Thanks for
question.
the question, Dr. Libby. Any other questions out there that we can help you with today? Dr. Bayan, Kendall, Lori, feel free to unmute yourselves. Go ahead, Kendall.
No questions from me, just really here to learn and support anywhere I can.
All right, no problem. If anybody does have questions during the presentation, feel free to write in through the chat box or unmute yourselves. So we will get going here then. So this is just our disclaimer letting you know that we do record all of these sessions. So if you don't want to be recorded, if you don't want to be on video, let us know and we can edit you out. And if you do decide to present a patient case, just don't share any protected health information, please. All right. Go ahead.
All right, so again, you've met all of us that are hub members, except for Dr. Conright, who will be with us next session. So we're going to move on to the next slide, which is our learning objectives. We're going to review the differences between palliative care and hospice care. We're going to define the hospice benefit, identify the interdisciplinary team members. We're going to look at the 4 different levels of hospice care and identify the primary hospice diagnosis with a little bit of criteria. And then we're going to discuss the differences and the changes in the funding. That'll be the Medicare funding. So next slide on this.
And P.S. the title of this echo is Hospice 101.
Apologies ahead of time when, so I'm calling in from Las Vegas. So when we don't get to be right in the Reno Project Echo offices, it's a little bit more difficult. So I appreciate your patience on that. And again, since it's a small group, jump in anytime with any questions or again, if something triggers a patient that you may need some focus and some support with, that's what we're here for. So, so palliative care is anytime during the illness, and it can be combined with curative. So if it's an oncology patient that is currently getting chemo or radiation, it's a great time to come in and have the palliative care. Typically, it's done with community resources and support. It's coordination of really the transition from education, patients' families, the course of the illness. So that can be palliative care a lot of times at a new diagnosis. It can be a big part of it. And then as the prognosis and the diagnosis progresses, it can go further away, if you will, as they are seeking just the aggressive treatment. Hospice care, the biggest difference is really it's that end stage prognosis of less than 6 months of life. It's focused on the comfort care, not curative. So we're really also focused on the patient, but the patient's friends and loved ones or their family. So we do a lot of caregiver support. We do also bereavement, volunteer, and the counseling. And that doesn't just stop when the patient passes on. It continues for 13 months after the death. So a little bit of history of the hospice benefit. 1963, I love this. Dame Cicely Saunders introduced this idea for the specialized care in the United States. And then in 1967, she went on to create the first really official hospice, and that was done in the United Kingdom. It still operates today. St. Christopher's is a very, get a chance to ever see it. It's an amazing place and an amazing care they provide. In 1972, Dr. Elizabeth Kluber-Ross is the first person that actually testified nationally on the subject of the death with and dying with dignity, and for the special Senate Committee on Aging. In 1982, Congress included the provision to create a Medicare hospice benefit, and in 1983, it actually, the regulations were really established. So, and that's also when the first Joint Commission accreditation existed. So that's really our history. I will tell you, hospice is, it is very much changing right now, and there is quite a bit of legislation in front of Congress to look at and to make some different changes. So if you're not paying attention to it, we all really need to, because it's definitely going to affect not only who we care for, but how we get to care for them. So next slide. This one again, what is hospice? Again, patients and their families are at the center, and then all of these other discipline or team members get to support the patient and their family. So the model of the quality compassionate care for people facing their life-limiting illness, hospice provides that expert medical care, pain management, that emotional, spiritual support, and it's expressly tailored to the patient's needs and wishes. So although we have nurses on here, the Medicare Hospice Benefit only requires a nurse to see the patient once every 14 days. The volunteers may not ever have to see the patient or may never get the opportunity to, but they also could spend 4 or 5 hours a day with some patients. The physician is really the key to it. That is who your physician is, the one that refers typically to hospice, and is also the one that certifies a hospice patient. So currently most hospice patients have their costs covered by Medicare, and it's through the Medicare Hospice Benefit. And typically the hospice is delivered in their home. A family member serves as really their primary caregiver, and if it's appropriate and when appropriate, they help make the decisions for the terminally ill individuals. Members of the hospice staff, again, we make regular visits to assess the patients and providers what they need with additional care. So again, hospice can be very much front-loaded, and then as we get the patient stabilized in whatever they call home or where they call home, then services can temper back, and then as it gets closer to the end, they typically will ramp up, and we'll talk about that further as we go on in the presentation. So these are all of the team members that can be used at any time, every day if need be, or on an as-needed basis for those patients. Next slide. Again, just a different way of looking at it. The interdisciplinary team meets every 2 weeks to go ahead and talk about what's going on with each of these patients. An individual care plan is required for every single hospice patient. So we manage their pain and symptoms. We assist again with the patients and their families' emotional, psychosocial, spiritual aspects of dying. We provide the medications and the medical equipment, so that is no longer at the cost of the patient. It's at the cost and delivered to the family in the patient's home. We instruct the family on how to care for the patient. We provide the grief support for counseling, and again, the grief support is 13 months. We do the short-term inpatient care as well as respite care, and we deliver any special services, whether that's physical therapy. We do a lot of speech therapy with CVA patients as well. And we really want to be there for all those things that happen after the patient passes for the grief support. Next slide. One thing that makes hospice uniquely different is that the U.S. hospice movement was founded by volunteers and the volunteers continue to play an important and valuable role in hospice care. So hospice is unique that we are the only provider with Medicare conditions of participations, those COPs that we all hear about, that require volunteers to provide at least 5% of our total patient care hours. And when I was preparing for this presentation today, we have a fairly large census here in Las Vegas, 3 times the national average. And it was pretty astounding to me to find out that 68% of our patients, we're the only people that see them on a regular basis. It's the hospice staff that gets to see them, meaning they don't have anyone else coming in their apartment, their home, their care home to see them. So when we are able to provide a volunteer to sit with them and spend time with those patients, it's really vital to just their mental health, and also just for them feeling like they're a valuable, because they are a valuable person in our world. And so we provide a lot of what we would call direct support, through our volunteers. And I know that just really makes it really wonderful. 2 days ago, we celebrated 105 years for one of our patients, and we had 9 volunteers that showed up for the celebration. So that was pretty exciting. And we also had quite a few staff members as well. Volunteers also provide the clerical and other support within our offices, and also can do some clinical support as well. They do some fundraising. They really, again, are trying to have, we have pet therapy, we have music therapy. The pet therapy go into our assisted living facilities or the skilled nursing facilities, and although they are there to see one of our patients, they also bring a lot of joy and companionship to the others that are around them. So there's all different ways to be a volunteer and to serve for volunteers, but we cannot be compensated by Medicare without 5% of all of our hours being brought to us by volunteers. So next slide. Bereavement services, again, counseling and grief support for the patients and their loved ones. Typically, hospices go ahead and send out a handwritten card or acknowledgement on the death. Then another piece of literature is sent out, typically, again, 14 days after death, and then on the birthdays or any significant anniversaries, and then obviously the anniversary of the death. Additionally, a 6 and 9 month spiritual acknowledgement and some resources is required by Medicare to be mailed or sent to the patient's loved ones. And again, that could be a family member or someone that's near and dear to them. So the bereavement services are very different, and a lot of hospices go ahead and do provide that to the community at large free of charge. And so typically they will do one-on-one counseling as well as group counseling at minimum of once a month, which is best practices for their patients and family members. Next slide. So who receives hospice? The most recent and current data available is 2017. So all of these numbers and statistics that we'll be sharing with you today are from 2017. So in 2017, 64% of the Medicare hospice patients were over the age of 80. And again, that's a high number, right? But the mean is right at 88 patients, so 88 years rather. In 2017, majority of the Medicare hospice patients were Caucasian, and the Asian and Hispanic have increased by 32% since 2014. So there is a lot of diversity and programs going on out in our communities as a whole. So the primary diagnoses for hospice, it's, again, won't be too many people on the surprise on this one, but it is oncology. The cancer patients have always been the ones that are typically really gravitate to hospice first. However, your stroke and cardiac as well as respiratory have had a significant increase since 2014. Next slide. So this really breaks up the nation and who's being served. And again, the Medicare, this is based on 2017 data. 1.49 million Medicare beneficiaries received hospice in 2017, and that's up 4.5%. Let's see. The portion of the Medicare descendants, if you will, that received hospice or were eligible to receive it, it is only 48% across the United States. So although as you can look at this map, you can see that some areas there's higher saturation, there really is a lot of opportunity to have palliative care and then hospice services provided to those that are really in need of it. So the percentage of hospice patients enrolled in a Medicare Advantage plan in 2017, this went up by 34% from 2012, which is really when the data started. I'm sorry, it rose from 26.8 to 34% in 34.7% in 2017. The increase of the hospice beneficiaries with the Medicare Advantage enrollment plans, it's consistent with the overall increase. Now I mention this because most people who are really involved in end of life really believe that there will be a carve out starting as soon as 24 months. And what the proposal is with that is that the Medicare Advantage plans can basically have and hold their own Medicare hospice benefit instead of it being diverting back to Medicare. So if everyone understands that if I have a we'll just use Humana or an Aetna or a Blue Cross medical advantage plan, Medicare Advantage plan right now, if I was to elect hospice, it would go back to the Medicare as being their primary. And that does, or could be possibly changing as soon as 24 months from now. So just something to keep in mind. Next slide. What did Medicare spend on hospice? $18.99 billion in 2017. Again, it's up 6.3%. As we all know, baby boomers, we're just going to keep on going up with these percentages each and every year. The average spending per patient is $12,722. And the spending per diagnosis, as we talked about, again, the dementia is the highest cost currently. Level of care, again, as we said, hospice really is designed to be given in the patient's home, wherever they call home, and that's at 93% of the spending. 20% growth in the inpatient respite, which is wonderful. So respite care will go into further, but respite is, again, when we just do that, we give that patient family some time to rest. So next slide.
Kim, question here. Do you think it's a good thing to have the Medicare Advantage plans able to manage the hospice benefit?
Ooh, that's a loaded question. Here's what I know that I know. I'm often asked, are you ready by a Medicare plan? As recently as this week, are you ready to go at risk with us? And I say, I've been at risk with you ever since I took on the Medicare patient. We're given a specific dollar amount, which will go in as this goes on further, per day to take care of the patient. How I spend that money, Medicare tells me I have to do these minimum things, and I make sure I do that, but then the rest of it, I get to kind of choose and decide what else I can do for that patient. So what I do know is some Medicare Advantage plans are going to minimize what hospice does and what hospice care is about. Maybe cutting out that bereavement for the family members. Maybe only having the nurse go once every 30 days and a CNA only once, never, I don't know. Or maybe they're going to even cover less meds. I just think that they're at risk, and it's so much not focused on the patient. Having Medicare hold what is our guidelines, there's still plenty of things that make each hospice different and unique. And so I'm not sure how I feel about that, but here's what I'm sure of. It's happening. And with 36% now of the Medicare beneficiaries on a Medicare Advantage plan, I have to be part of it. So I'm hoping to make the difference and partner with those good Medicare Advantage plans that are still going to keep the patient and their families at the focus. So I know that might have sounded a little politically correct, but
Thank you.
It is, because it's happening.
So, and Kim, I think one thing I just would like to add is that though these Advantage plans will be offering these hospice services, does that necessarily mean that the conditions of participation or the COPs will be changing or updated?
Okay, so the way that it's going now, those plans would have the ability to set their own.
Okay.
And that's where it gets a little touchy for me.
Right. Exactly.
Because the consumer really won't know what that means. It's so complex to choose your own Medicare Advantage plan, let alone most people don't think about when it's time for hospice of what that looks like.
Right.
So right now, CMS sets the kind of the hospice guidelines, and so that'll be transitioned to more of the, for lack of a better word, insure.
Correct.
What qualifies you for hospice?
They don't they do set it.
Okay.
Now there are a lot of programs going on and pilots, and there's a lot of different names for them across the country where some ways they're looking at, is it 6 months longer required, or could we even go 12? Could we bring it in sooner, quicker, faster? So those I think are great things, but change is coming. Change, I always have said, is our only constant. So we either have to be a part of it or we're going to be left behind.
Thank you. Appreciate that.
You're very welcome.
Oh, it's this one. Yeah.
Yeah, so again, real quick, 45 115 Medicare certified hospices are in operation. Here's a quick and fast thing. There is no way you cannot be Medicare certified and be a hospice. Just to give you an idea of those patients I was sharing with, we're at 99% of all of our patients are Medicare. Now, mind you, we have a significant amount. We have a 40% that are Medicare Advantage before they came on to us, but you have to be able to provide hospice services with Medicare. It's just impossible not, because again, remember, everything flips back to Medicare once you choose hospice. So the average census for a hospice, again, is 63, and the mean is about 50. I will tell you, currently in Nevada, we have 88 Medicare certified agencies. 51 of them are certified here in Clark County. It's very competitive. So versus an at-need state, which California is an at-need state, Arizona is just like us. You can open up if you can. Very different. So I'm going to turn it back over to Dr. McCaleb.
All right. Thank you so much. So I'm going to start my portion of the presentation with a case study. Mrs. H, who is a 91-year-old female who has been suffering from COPD and chronic obstructive pulmonary disorder and CAD, coronary artery disease, for over 35 years. She is a DNR and has an advance directive with her. She was taken to the emergency room by her daughter, who believes that her mother, Mrs. H, has pneumonia. Mrs. H was put on CPAP in the emergency department. An IV line was started, blood was drawn, and a chest x-ray was taken, while discussions ensued regarding whether or not a course of aggressive treatment or a course of more comfort-based treatment was going to be pursued, given her illness state. So Mrs. H does not want to be admitted to the hospital. Her daughter is concerned that she can no longer care for her mother at home in this current condition. So this is specifically general, and what I would like to ask is, what are some of the options for Mrs. H if she and the daughter, so it sounds like the patient really wants to pursue a comfort-based path, and if the daughter also shares that and that's the decision they arrive at, what are some of the options for her care at this point moving forward?
What setting are you seeing the patient in?
Right now she's in the ER.
Dr. Bayan, Lori, any comment on that?
I'm okay, appreciate it.
So there's several options for this patient. We're going to discuss in the next few slides the levels of care that can be included with hospice services, because certainly if the patient is on board with comfort and that is the option the family decides to move forward with, then I would advocate that this patient is appropriate for hospice services. She is in an acute illness state. She has at least 2 chronic diseases. And if she refuses admission for a standard pneumonia, the likelihood of her dying from this disease process as a 91-year-old female with these chronic comorbidities is exceedingly high. And so certainly one of the options that would commonly be presented would be discharge to home hospice. And in fact, that would involve the care team of physicians in that setting and the family. And it would have to be made clear that the patient would survive transport to home, just to add sort of an additional layer to this. However, it wouldn't be unusual for a patient like this to be able to tolerate a transition to home hospice. There's a couple of other options that I want to talk about that we'll get to through the presentation. The other thing is that if this patient came on to home hospice services, what would we list as her hospice qualifying diagnosis?
End-stage COPD.
Yeah, we could call it end-stage COPD. That's exactly what I would call it. So more specifically, just because you would fill out the death certificate with pneumonia being the underlying cause of death, you would certainly make note that COPD, the underlying disease process, was part and parcel to her susceptibility to the pneumonia and her inability to tolerate the disease course of pneumonia as a standard intervention that could be treated, let's say, with oral outpatient antibiotics in somebody who was not and as frail and or as advanced in her illness course. So there's 4 levels of care that are defined by Medicare in the conditions of participation. So the most commonly used of the 4 levels of care is routine hospice care. Routine defines hospice care as care that's being provided by a hospice agency for a patient in their home. And the definition of home is wherever the patient considers their home to be. The 3 other care options under hospice are continuous home care, and this is care that's provided for anywhere between 8 and 24 hours a day to manage pain and or other acute medical symptoms in that home setting. So basically, another way of thinking about this is crisis intervention. And typically the crisis for institution of continuous home care must be an unmanaged symptom. That would be the primary purpose for instituting continuous home care, so that urgent efforts can be made at symptom control in the environment of the patient's choice. And so when we look at continuous home care, we also think about other crises that home hospice patients can have, which can be a total breakdown in care, where these individuals are left without a caregiver. If somebody's on home hospice and they're bedbound and they're being cared for otherwise by their spouse, and their spouse has a sudden urgent medical event and becomes hospitalized, and now that person is at home alone, that's not necessarily a reason to institute home care, even though it would be, as long as you had a plan for how that patient was going to be dispositioned from that point forward. Respite care is available to provide temporary relief to the patient and the primary caregiver. So the continuous home care might be instituted as a bridge towards respite care. And most hospice agencies have contracts with SNFs or long-term care facilities where their patients can be transported to and receive what would be otherwise the same type of care that a frail geriatric patient would receive while, let's say, a caregiver was making a plan to leave town. So respite care is available to provide temporary relief. The key is to the primary caregiver or in the absence of the caregiver. General inpatient care is provided for pain control or other acute symptom management that absolutely cannot feasibly be provided in any other setting than inpatient care. Okay, and that inpatient care can be provided in a facility, it can be provided in a hospital, but it cannot be provided and cannot be billed for a patient in their home. So GIP, the key word there is inpatient. And so that the hospice agency has contracts with agencies or hospitals to provide their patients with GIP level of care. So a brief overview of diagnosis and criteria. This is by no means any, I would not use this to qualify your patients. We're just trying to give you some generalized and generalizable sort of ways of looking at patients with the following common conditions and how they would qualify for hospice with a prognosis of 6 months or less. I would refer you to, again, going to the CMS guidelines, which are available online and are listed on the CMS website. But otherwise, cancer that's stage 4 with the declining functional status and unintentional weight loss meets our criteria for hospice. Cardiac, so advanced CHF, and the key here is disabling dyspnea at rest. And for coronary artery disease, we're looking at frequent angina where the standard interventions are no longer effective, and we are looking more at narcotic management as opposed to your vasodilators and things of that nature, which should readily relieve anginal pain. For respiratory, again, the key to making a diagnosis and admitting somebody to hospice might be a terminal condition such as pneumonia, where it's anticipated that the individual will not recover from an acute respiratory insult. However, just as with cardiac, the key is disabling dyspnea at rest. So looking at dyspnea at rest is very, very important for cardiac and respiratory patients. Much, much more so than a lot of the markers we sometimes discuss, such as a diminished ejection fraction or EF in CHF or advanced cardiac disease, and or a low FEV1, which is the expiratory volume that we look at in COPD patients. It's more about the patient's clinical experience than it is about numbers. Stroke and coma or being severely obtunded beyond 3 days with advanced dysphagia, preventing insufficient intake is part of our criteria for stroke. And post-stroke dementia is when we're looking at the FAST scale, which is a common tool to assess the degree of advanced disease. And so we look at our FAST scale, stage 7, and we also look at these complicating events, such as the one that Mrs. H had. And we also take into account multiple hospitalizations and multiple decubitus ulcers or evidence of skin breakdown and, again, weight loss. For end-stage renal disease, this is one where we can look at creatinine clearance and some of the numbers being a little bit more helpful in terms of guiding admission. But otherwise, somebody who is being offered but refuses dialysis and is anuric, meaning they don't produce any urine, would be somebody who would qualify for hospice based on end-stage renal. So keeping in mind that our stacking diagnoses, so we can make a strong case for hospice when there are multiple comorbid conditions. So looking back again at Mrs. H, COPD may be the driving underlying diagnosis for her, but also CAD is part of the picture for her.
Dr. Bayan, did you have a question for us?
Oh, no, I just listened through and got my question answered. Appreciate it.
Okay.
All right. One of the things that I think is important to mention is that it is the role of the hospice medical director to finalize the diagnosis and make the attestation to Medicare and also write a certificate of terminal illness. So that's just some added information for you. And also just to understand that there are patients who may qualify incidentally for custodial care where they have advanced disease processes, but they may not have totally entered what would be termed the terminal phase of their illness. And so these are patients who may not quite qualify for hospice, but are otherwise a patient who would qualify for palliative care. Hospice, of course, being a version of palliative care, but that ultimately, once somebody who is in the custodial phase of their illness enters the terminal trajectory and has a complication or their goals of care shift, then starting hospice care is really indicated at that time. So just for following up on our case study with Mrs. H, the hospice philosophy and benefit was explained. She was agreeable to start care at a skilled nursing facility under GIP. So remember, she had pneumonia and she had an underlying advanced disease process, and she also had the need for advanced symptom management. So somebody who requires new interventions such as oxygen or respiratory support under periodic CPAP or BiPAP is somebody who can be provided symptom relief, but also be on hospice. And there's no provision under hospice that says a hospice patient cannot receive antibiotics, either IV or oral. And so as long as a conversation has ensued that this could prolong their life in hospice, that may be part of their goals of care. And so as a hospice physician, I would absolutely factor that in and treat based on patient preferences or based on the recommendations from, again, she had an advance directive, so I knew who I could speak to. After 4 days of general inpatient, Mrs. H, her symptoms were stabilized, and she was transferred to home under her routine home hospice benefit, where she spent the next 51 days. Her daughter had to travel to Reno for work. And so during those times where her daughter traveled to Reno, 5 days of respite was scheduled so that she could be cared for in a setting that could meet her needs while her daughter was out of town, given her daughter was the primary caregiver. So on day 3 of respite, Mrs. H had a rapid decline and required readmission to GIP level of care for symptom management and anxiety. And so that shift in care, if she's in a SNF, can absolutely happen. The only level of care that would not be an option to her in that setting would be respite, or excuse me, would be continuous home care, because again, she's not in her home environment. So after 3 days of repeat GIP, Mrs. H was transferred to care at home, and she passed away comfortable in the home under home care 21 days later. So the nurse and social worker performed daily visits for the last 7 days of her life. So I'm going to now pass this over to Kim to finish us up on part of the 2020 Hospice Wage Index.
Okay, so this is not what we personally get paid for hospice care. This is what the hospice agency gets paid per patient per day. So I literally took this is listed on our resources. So again, CMS puts this out once a year, and it's done by counties, by state, and then by county. So again, you can see very quickly the routine home care rate, day 1 through 60. I'm just going to use Clark County, if you will. That's $220.21. Perfect. Thanks, Troy. After the 61st day, or on the 61st day, it goes down to $174.04. Now, the methodology behind this is hospice is very much front-loaded. We deliver all the equipment out there. We deliver all the meds. Typically, we're stabilizing the patient. So our cost per patient per day should decrease in that 61st day, or before that a little bit actually, and then level out. And it really makes a little bit of a difference on our costs and what we're doing. Now the next column, the third column there, that's $65.84. This is a relatively new add-on that CMS has provided. This means the final service intensity add-on. So what this happens is in the last 7 days of life, up to 4 hours of additional care provided by a nurse or a social worker can happen. And then we can bill $65.84 in Clark County per hour per day. Now, this is new. This did not happen to be that way. Now, here's kind of the risky thing is none of us have an expiration date on us, and no matter how good we are or how much we've done this, sometimes we get it really wrong. So I will tell you, we have provided plenty of the service intensity care and not been able to bill for it because the patient stabilized. So it is at risk, but again, you can, if you're doing it and you're doing a great job at it, you can bill additional money for it. The continuous care, going farther to the right, still staying under Clark County, $1,580.13, and then your respite care is at $496.98 per day. So if we can go on to the next slide, we're going to go ahead and take another, this is what we just talked about here. And then we're going to take a look at what the agency could have billed for Mrs. H on the following slide. So her initial first 4 days, remember she went straight from the hospital ER to a GIP setting in a SNF. So the hospice would be able to bill for those 4 days at $1,147, which totals $4,588.08. Then she was transferred, once they got their symptoms managed, to the daughter's home. And for 51 days, she was able to stay there under routine home care. Then, although 5 days of respite was scheduled, she only made it to 3 days because she had the acute setting. So they would be able to bill for 3 days of respite at the $496.98. And then 3 days of GIP. Now, patient was discharged GIP, she went to a care home for 21 more days. The first 9 days were billed at the higher rate, and then it went into that 61st day, so it was billed at the lower rate of $174. So those last days, again, were a total of $4,070.37. The service intensity visits, again, it's billed hourly. It can be a social worker or a nurse. It doesn't have to be and, it can be or. And I just use as this example for Mrs. H, it was 3 hours a day. You can bill up to 4, and you can bill up to 7 days. I will tell you sometimes we're only billing up to 3 days. Our best practices with the agency I work with is that we really do try to do daily visits. And if the patient is needing it and wanting it, in the last 7 days of life. So you're able to bill an additional amount in addition to the routine home care per hour up to 4 hours a day. So the total amount that this was eligible, and when I say eligible, because you have to make sure your documentation really supports all of this, would have been $26,203.80 for Mrs. H's care for those 82 days. So if we do have any interest, we can definitely do a much deeper dive into the billing. I will tell you, it's just as bad underbilling as it is overbilling. So billing is definitely a focus with CMS for hospice right now.
And the only thing I would like to add is that, it absolutely Kim makes a very, very important point that we don't have expiration dates, but what this sort of approach to billing that hospice has prescribed under CMS really allows for, when you really think about, let's just say, so I'm going to go back to the slide where we showed the add-on services. So for Clark County, that was the 60 some odd dollars that Kim mentioned that could be started in the final 7 days of life. So what this really encourages is that hospice teams should be very united and know their patients very well, because ultimately patients on hospice are going to have a terminal changing condition. But it's always, questionable for us if a changing condition in a hospice patient is actually going to be that final terminal changing condition. And sometimes that depends on the interventions that we mentioned up front with Mrs. H, which included her desire to continue to proceed with IV antibiotics. So potentially, let's just use her case again as an example. If she came onto hospice with COPD and developed pneumonia and was essentially treated, she did have interventions that were all geared towards her quality of life and towards her comfort, which included, let's just say, oxygen breathing treatments and even those antibiotics that we stated up front. Her goals of care during her course on hospice may have shifted to the point where she now realized that for any other changing condition, she didn't want to re-experience IV antibiotics, that she didn't want to re-experience any further escalation in her care, or she even didn't want to continue currently acceptable goals, which included the antibiotics. And so incorporating the expertise of the hospice social worker, incorporating the expertise of the hospice chaplain, these hospice team members are absolutely crucial in helping evolve patients' expectations from the hospice care that they're receiving. And so, that might be one area where then when a changing condition was identified by the hospice team, and let's just say that the daughter called and said, well, my mom's not doing well. Well, the hospice nurse could come out, do an assessment, report to the hospice physician, say she's had a changing condition, but spoke with the chaplain last week, no longer wants to receive interventions or antibiotics for this. And so because of that, we would continue the comfort care at home, for example, but we might not do the antibiotics, and then we could start the 7 days of billing, the add-on, knowing that it was more than likely that now a second pneumonia with somebody who already we said we expected not to live for 6 months could be the final terminal changing condition. So I'm just giving that sort of as a very explicit example of how medical decision-making can be influenced by the hospice medical director and in concert with and equally at the table with the members of the hospice interdisciplinary team.
Go ahead.
Any questions either about the case or questions in general about what was presented?
I have a question about cost. I have a question about the cost. So, according to Mrs. H's case, it looks like we can bill $26,000 and change for all of her care, but do we know like what the actual cost of care is for any of the patients that kind of hospice takes care of?
That's a great question, and that will definitely be something that we can, if there's interest, doing it into the next session. I will tell you, when CMS does their budgeting, they take an average in there. They don't want to do a profit of more than 10% typically and less than 5%. They feel that that's really a right operating budget for a hospice. I will tell you, I know agencies that operate at a higher budget than that or less. Very simple, that I can share with you some of my contracts. So we'll use Mrs. H's case again. General inpatient care, yes, I can bill $1,147 for it. But right now, just for a sniff, because it only can be done in a sniff, I pay the sniff $700 for the bed. Then I have to bring in the meds. Then I bring in my staff. Then I bring in like maybe the O2 concentrator. Then I bring in the social worker. Then I bring in the CNA. Oh, and then that physician needs to go see her too. I pay them for a visit. So pretty much a loss leader. Respite the same way. We pretty much give most of our contracts read 95% of Medicare allowable. So that whole $475 a day, 95% of it goes to the facility. I'm definitely losing money in that because of the facility, I'm bringing in the meds as well. So, and that is why they again do the front loaded and a little higher on those routine home care patients. So
Why is hospice so competitive then, if the margins are so poor?
Ooh, another loaded question, doctor. Hospice is not always, why am I always on the hot seat on this? It's not always so competitive in other markets. Remember what I said earlier, that we have 81 hospice agencies licensed in Nevada. California, much larger population, because it's an at-need state, typically only 3 hospices are allowed and licensed in a certain demographic area. Not nearly as competitive. Wouldn't be surprised if that 81 dropped a lot farther down as things get more and more competitive. Meaning again, competitive and competitive in the national arena where we go at need state.
Okay, and I guess the natural assumption is the reason that we have more hospices in Clark County is the higher reimbursement rate that they get, based on that chart you showed? Or do you think it's more of the population?
Well, I can tell you up until about, because I have a lot of experience up in the Reno market as well, up until 5 years ago, y'all only had 5. So it's been the influx of your California residents that has brought a lot of those California companies there. So yes, we have a larger aging population in Clark County. And you have a lot of home healths now that are just adding on a hospice, as well as hospices adding on a home health. So that's really where in Vegas or Clark County, you have a lot more of the double agencies.
Thank you.
Welcome.
The only other thing I would add, and I know we're wrapping up like right now, but that is simply that a lot of times hospice agencies have inpatient hospice facilities for their agency. And so some of that GIP care and some of that can be maintained in-house, but in Northern Nevada, at this time, we do not have what's termed an IPU or an inpatient unit for any hospice agency in Northern Nevada.
So it all goes to SNPs.
Correct. So it all goes contracted out to SNPs or some acute hospital care.
And I will tell you, in Southern Nevada, we just had our 4th GIP or a general inpatient facility open up this week. They took their first patient, and it's a community. It's a 14-bed. It has to be licensed with a agency in order to be licensed as actually licensed as a hospital. That's a requirement in the state of Nevada. They're only keeping 2 beds for their own agency, so 12 beds are community. This is the first time it's ever been done like this, so we'll see. Like I said, they've had 3 patients as of now. So.
Part of the evolving model. So thank you guys for being here today. Kelly, Dr. Bayoun, and Lori Stanfill, thank you so much.
Yeah, thanks everybody. So we'll be back next month. February 21st is the date for that session. So Friday, February 21st at noon. Hope to see you then. Thanks everybody. Have a great weekend.
Have a good weekend. Thank you.
Thanks, Dr. Bayoun.